Good morning, everyone. I'm Dr. Deborah Siegal. I'm a hematologist in thrombosis medicine in Ottawa, which is in Canada. And it's my pleasure to welcome you today for this session. Thank you so much for attending. And thank you to AstraZeneca for their support of this unrestricted medical education grant. And hopefully we'll have some good discussion today. So we're going to be talking today about an update in anticoagulation reversal. I'll just let you know that we do have some audience polling questions, and we're going to be doing this old school by using cards. So we encourage you to answer questions simply by raising your card and try to raise it high so that we can see it. Yes, no, and hopefully we'll have some good discussion. We have about 15 to 20 minutes for presentation, and then we can have some Q&A. So these are the objectives that I'm hoping that we'll accomplish today. After reviewing this presentation, that you'll be able to describe the burden of bleeding in general and in patients with intracranial hemorrhage in those who are on anticoagulants. We want to also talk about a multimodal approach to managing anticoagulant-related bleeding. Administration of reversal hemostatic therapies is obviously an important part of management, and these should be used judiciously in patients with serious anticoagulant-related bleeding. And finally, apply best practices to restarting anticoagulation after bleeding, which is an important, controversial, and challenging thing to do many times for our patients. So why don't we set the stage first with discussing the burden of the problem. I'm sure you're all aware that anticoagulants prevent and treat cardiovascular disease, and still, this is the leading cause of morbidity and mortality worldwide, estimated to be responsible for 18 million deaths. And I say this not because you don't know these data, but it's actually helpful to tell patients and families and colleagues who may not be as familiar just how important this issue is. In North America, which is where I live, there are 40 million prescriptions for oral anticoagulations, at least, probably more now, given every year for these to prevent and treat these diseases. And of course, direct oral anticoagulants, or DOACs, are increasingly used now, recommended by guidelines, preferred by patients and practitioners for the ease of use, a reduction in bleeding complications. And we're seeing now that the factor Xa inhibitors are increasing over the direct thrombin inhibitor like dabigatran and over warfarin, as you can see in these slides. So this is our first opportunity for polling. How many of you in the audience have seen bleeding complications in your patients treated with DOACs? So yes, if you have. And then no, Carrie, thank you. Sorry, not to point. Yes, we have one honest person in the audience. Thank you very much. Really common. We've all seen these complications. So I'm glad that we're here today to talk about it. Because even in 2024, bleeding is the complication that limits our use of these drugs. They work really well to prevent and treat thrombosis, but they increase the chances of having bleeding. And we still see bleeding rates around 2 to 4% per year among anticoagulated patients. And then another 10 to 12% of those patients experience what we call clinically relevant non-major bleeding. And this is dependent upon the population and the drug under study, but just to give you a sense of, these are relatively common complications. We use DOACs preferably over warfarin for some indications because of the reduced chances of intracranial bleeding, which is the most feared complication of anticoagulant use. Also reduced major bleeding, and there may be a signal for an increased risk of GI and possibly genitourinary bleeding. And there may be some head-to-head differences between DOACs that have not yet been proven in clinical trials, although there are some that are about to be completed. So we'll have more data on that. Again, these complications are the most common adverse drug events that lead to hospitalizations, emergency department visits, and even death. So important drug class, and I guess that's why we're all here and why I do the work that I do. So, okay, this is the second polling question. Of the bleeds associated with DOAC therapy, which would you say are more frequent? Raise the card if you think extracranial bleeding is more frequent or intracranial bleeding is more frequent. We've got extracranial bleeding depends on your clinical practice, I guess. If you're a stroke neurologist or a neurosurgeon, maybe you see more intracranial bleeds. But in fact, extracranial bleeding, or particularly gastrointestinal bleeding, is the single most frequent site of anticoagulant-related bleeding, representing about 50 to 60%. You can see from this slide, this is a combination analysis of the RELY and active W trial. So patients treated with dabigatran or warfarin and RELY and warfarin in the active W trial or aspirin. And you can see on the left-hand side, hemorrhagic stroke, very serious complication, almost a 30-fold increase in the risk of death among individuals who had hemorrhagic stroke compared to those who had no bleeding. In the middle, you see subdural bleeding, common in our elderly patients, sometimes spontaneous, sometimes traumatic. Those can be different and have different prognoses, but again, 7-fold increase in the risk of death. And then finally, extracranial bleeding on the right-hand side, where I spend a lot of my time doing research, 5-fold increase in the risk of death for individuals who have extracranial bleeds, like GI, again, the most common single site of bleeding. This is a nice sub-analysis from the Aristotle sub-study, And Aristotle, of course, was a randomized controlled trial of Pixaban versus warfarin for atrial fibrillation. This slide shows you 30-day mortality after major bleeding, and you can see at the top in blue, intracranial bleeding, very high 30-day rates of mortality, 43%. But I'll draw and of course, it almost overshadows this extracranial bleeding line, which is red and looks flatter, but still extracranial bleeding here, 9% of patients died at 30 days. So that means if a patient comes in with a gastrointestinal bleed, the likelihood or chances or frequency of death in that population is almost 10%. So let's talk about management of bleeding, because again, these are the kinds of outcomes that we want to avoid. I like to think about bleeding as a framework or a spectrum of activities. Now, we often will focus on anticoagulant reversal, and that's one of the reasons that we're here today, but really it encompasses so much more than that. And so it's very important to maintain a holistic approach. And this slide shows on the top left-hand side, the first step is really to recognize that a severe bleed is happening. Now, in the brain, that might be pretty straightforward, but other cases it may not. And I encourage you to think about not just the bleed characteristics, but also the patient who's having the bleed. I know it's a different scenario for a person like myself who has a gastrointestinal bleed versus an 88-year-old multi-morbid, frail individual with dementia. Then, of course, we're going to think about reversal or hemostatic therapies, which are indicated for individuals who have those severe bleeds. Finally, we're thinking about reassessing anticoagulation after bleeding, and this is a complicated and individualized thing to do. And then prevention, which is really, I think of as the first step, but it is also the last step. And really, that's at the end of the day, we want to try to avoid bleeds in the first place. If we have one, we certainly want to avoid another one from happening. It's important to institute supportive measures right away. You know, what's going to save a patient's life if they're bleeding, have a life-threatening bleeding complication, retroperitoneal, and they're hemodynamically unstable, or gastrointestinal and they're unstable, fluids, transfusions, that's on the left-hand side. Different measures when you're talking about intracranial bleeding. Of course, we have attention to things like airway and breathing, looking at the severity of bleed with deficits, blood pressure control, extremely important, and neurosurgical referral. And all of these can be packaged within institutional protocols that are adapted to a local context, which is really helpful to do. So, are you aware of approved medications that were developed to specifically reverse anticoagulation on DOACs? Yes. Thanks for doing a good job with the cards. But of course, those agents are available, but are to be used judiciously for patients most likely to benefit. And those are people who have severe bleeding and who have clinically significant levels of DOAC measured or suspected. And to be honest, we're not going to go into it too much, but perhaps in the Q&A, how you know someone has clinically significant levels is because maybe you have a really rapid access blood test available, which most of us do not. But alternatively, and more importantly, the patient's bleeding out in front of you, you want to know when they took their last dose, and you want to know their renal and liver function. And though that information is really important to act quickly. Because as a good colleague of mine says, time is brain for intracranial bleeding. There's not very much space or room to move in there. So this is a slide. We're going to focus a little bit into intracranial bleeding just because some of the data that's recently come out. This is from the 2022 AHA-ASA guidelines that make recommendations around how to manage anticoagulant-related bleeding. You can see vitamin K antagonists, dabigatran, factor Xa inhibitors, and heparins on here. Let's focus in on the DOACs for this purposes of this talk to say right there on the fourth box from the top, you see when was the last dose taken? Most important thing you're going to ask right away. Activated charcoal is there. I don't know if anybody has used activated charcoal in their practice. I have not. It's always there. I'm not sure it's practically useful. But what this guideline is saying is that if a specific reversal agent is available, then that is preferred based on class 2A or 2B guidance. And in this study, again, no randomized trial data at the time. And if the specific reversal agents aren't available, then a non-specific hemostatic therapy like PCC or activated PCC. So for dabigatran, of course, we have the availability of idarucizumab, which is a monoclonal antibody against dabigatran. Other treatments that can be used in the setting of dabigatran-related bleeding are activated PCC, or so-called FIBA. Unclear what the maximum or optimal dose should be. Is there a maximum? We're not sure. Again, it was an agent designed to be a bypassing agent for hemophilia patients with inhibitors. 4-factor PCC is what most of us use in our clinical practices. Again, unclear what the optimal dose is. Sometimes people use a fixed dose. Sometimes it's a weight-based 25 to 50 units per kilogram. For factor 10A inhibitors, of course, andexanet alpha is approved in many countries, including Canada, where it's not yet available in hospitals, but it's coming. And andexanet is dosed according to the type of factor 10A inhibitor that was taken and the time that it was taken since the last dose. In another treatment that's been used, I'm sure, in many of your settings is 4-factor PCC. Again, uncertain what the optimal dosing strategy is. Many settings use 1,500 to 2,000 units, or alternatively a weight-based strategy of 25 to 50 units per kilogram. Unsure if we should be using a max dose. In the product monograph for warfarin, at least in our country, for our agents, there's a maximum dose recommended of 3,000 units, but that might be dependent upon the products that are available to you. So putting up this study, this is a recent publication. This is a propensity-based, a population-based propensity score-weighted retrospective cohort study of individuals presenting with intracranial bleeding on direct oral anticoagulants who either received PCC or conservative management without PCC. And you can see here from this slide that the patients who received PCC did not have improved outcomes compared to those who did not. And that would include things like hematoma expansion or mortality. And this was a single country study done in China. We don't have, prior to this study, we didn't have comparative data in this manner. Anexa-I has recently been published, as I'm sure many of you are aware. This was a randomized clinical trial which evaluated andexanet alpha versus usual care, which could have included PCC, for individuals presenting with intracranial bleeding on factor 10A inhibitors. And you can see from this slide that in those individuals who received andexanet alpha, the primary efficacy endpoint here, which was effective hemostasis at 12 hours, was higher than among those who received usual care. So there was a 13% increase in effective hemostasis with andexanet compared to usual care. 86% of individuals in the usual care arm received PCC in this study. It's also important to keep in mind that these outcomes of effective hemostasis were adjudicated by an independent committee. And I should also mention that these definitions that have been used, not just in Anexa-I, but in REVERSE-AD and other studies, Anexa-4, were developed in collaboration with the FDA for the Kcentra registration trial. That was PCC versus plasma for warfarin reversal, and Dr. Ravi Sarod. So just to say that these are standardized definitions and they're bleed site specific. Sometimes people wonder where these definitions came from and how did they arise, but that's kind of how they arose. As you may also be aware, thrombotic events and mortality were measured as a part of this study out to 30 days. And you can see that in the andexanet alpha arm, there were more thrombotic events, 10% versus 6% in the usual care arm, and that was statistically significant. You can see that this included events like ischemic stroke, which was statistically different, and also myocardial infarction. About a quarter of the population in this study died within 30 days, similar mortality rates in both arms for this study. We can talk more about these data in the discussion period. Prior to Anexa-I, lots of individuals have published, these are just a few, published cohort studies from their own institutions evaluating the outcomes of individuals who came in with severe bleeds on DOACs and received treatment. So these are also single-arm cohort studies without control groups. And I think what you can appreciate in red is that effective hemostasis here, according to definitions that are consensus-based, was around 70 to 80% in most of these studies. And the thrombotic event rates ranged from 4 to 10%. These are patients who are prothrombotic at baseline. They're on an anticoagulant for a reason. They come in bleeding, so their coagulation systems are activated. Maybe they've gotten hemostatic therapies or need surgery, all of which increase the chances of getting thrombotic events. I also just want to caution you that when in the setting of a high mortality rate, as we've seen in some of these studies, we really have to keep that in mind when looking at thrombotic events. So if we look at Majid 2017, on the left-hand column, you can see the death rate there was 32%, and the thrombotic event rate looks really low among people who received PCC. We just have to keep in mind that unfortunately a third of that population died and wouldn't have been counted as part of people who would have received, who could have gotten, or who are at risk for thrombosis because of that. You can also see on the right-hand side in the Annexa-4 study that only a third of people started some type of anticoagulant, and only a third of them started an oral anticoagulant. So there are some really interesting sub-analyses that are coming out of the Annexa-I study. I think we're all interested to know a little bit more about the details of the events that unfolded during the trial, particularly the thrombotic events. There are some studies that suggest that individuals who present with a larger hematoma may benefit from andexanet compared to usual care, those with a high hematoma growth rate, and those who present earlier after symptom onset. Again, these are all hypothesis generating based on some analyses that were presented at international conferences. On the other side, you see individuals who have smaller hematomas, particularly if they present late, if there's a later presentation after symptom onset, like the damage is already done, those who have a history of thrombosis, and then those perhaps who have a poor baseline functional status coming in the door, that may favor no treatment with andexanet. But again, these are still to sort out, and a lot of folks around the world are working on not only analyzing and publishing these data, which we're hoping to see soon, but also how to incorporate this into their practices in a protocolized fashion. And so I'll just spend the last 2 minutes talking about restarting anticoagulation after bleeding. And I think it's always important to remind people that not all bleeds are the same. Even in the cranium, there's differences between, again, traumatic versus spontaneous, subdural versus parenchymal, huge difference. So there's no one-size-fits-all approach. And so I encourage you, when you're thinking about this issue, is to use an individualized approach. And these are some principles. By no means this is the only way to manage, but I think this has the opportunity to not be dogmatic, but to just bring in some concepts here that are helpful. Has the bleeding stopped? Well, we're not going to give anticoagulants to people who are actively bleeding. Is there an ongoing indication for anticoagulation? I think this is our good Samaritan duty to stop anticoagulation for people who no longer require it. And we do that actually not infrequently. And then finally, you're weighing the thrombotic and bleeding risk. And this is actually really hard to do in clinical practice, but I encourage you to think of not just the thrombotic absolute event rates, but also the type of thrombosis. A stroke from AFib is very different than a deep vein thrombosis. There's short and long-term differences in outcomes that are very important to keep in mind. Same thing with bleeding. What's the risk of rebleeding? Where is the bleed likely to happen? Is the bleed amenable to intervention? And then short and long-term effects. Spontaneous epidural hematoma, I can tell you, is a really terrible prognostic condition. I just saw a patient with that type of problem. So I think we just need to be careful about how we categorize these things. Shared decision-making with patients and caregivers, and the folks who also participate, neurosurgeons, gastroenterologists, very helpful. So finally, if we start anticoagulants after bleeding, it appears that we reduce the risk of thrombosis. This shouldn't be a surprise to us. These are data from the Annexa-4 trial, in which individuals who had restarted anticoagulation, there were no thrombotic events in that group. So I'll just end here. I think I'm on schedule. And I'll leave out these takeaways. Just that the use of DOACs to prevent thrombosis and treat thrombosis is increasing, and along with it, bleeding complications. Of course, intracranial bleeding has the highest mortality and also morbidity, significant functional impairments after intracranial bleeding, particularly parenchymal bleeds among survivors. There are targeted medications that reverse anticoagulant effect, andexanet for factor Xa inhibitors, idarucizumab for dabigatran. And 4-factor PCC is available, and we're going to see it being used as well, I think, and looking for some supporting data, particularly around dosing and comparing different strategies. And then finally, make sure that you're considering restarting anticoagulation, or at least there's a plan in place to do so at some point, and that can be dynamic and revisited over time. And I'll stop there. Thank you so much for participating. I appreciated the nodding and clapping and signs. Thank you.
Thank you. Got disorientated there. One of your last couple of slides there's actually showing that those that restarted anticoagulation got no complication at all. I find that rather peculiar in terms of whether we are selecting the group that actually the bleeding that happened that caused the incident in the first place is not severe enough to cause death, because obviously if they unfortunately pass on during the bleed, they are unlikely going to actually be evaluated. So I think it's a self-selecting kind of process going on here. So I wonder whether we should be careful when the timing of the restarting of anticoagulation here. What are your thoughts?
Yeah, you can hear me? Thank you. Very important comment. I totally agree with you. And that's why I strongly encourage people to think about, why, what type of bleed it was and why it happened in the first place, because that's critically important. And there's a nice survey that was done looking at when people would restart when people would restart anticoagulation for patients with different types of bleeds, intracranial bleeds, but for different etiologies. So on one side of the spectrum, you had individuals who were found to have cerebral amyloid angiopathy. And the vast majority of survey respondents indicated that they would never restart anticoagulation. And then on the other side of the spectrum, you see people who had traumatic intracranial bleeding, and the vast majority of people would restart. The timing of restarting was variable. And actually, there is no evidence-based strategy to restart anticoagulation in that way. And you're absolutely right. In the studies that have been done, they're whole cohort studies of people treated in routine clinical practice. So we have meta-analyses that will show if you have intracranial bleeding and people who restart anticoagulation have a lower risk of arterial thromboembolism. In those studies, there was a similar risk of bleeding. But that's because, as you say, the patients who were selected to receive anticoagulants were likely different than the people who weren't and had a lower risk of bleeding, or physicians felt more comfortable or felt that they likely had a lower risk of bleeding. And that's why we see that, because we know anticoagulation increases bleeding and lower thrombosis. We're just trying to find that sweet spot of, when and how, but very good point. Yes.
I'd like to ask a question also. Nice presentation.
Thank you.
So the original Andexanet studies indicated that a large percentage of patients didn't have any serum or plasma concentration of DOACs in their assays, and yet they were given Andexanet to reverse bleeding. And then there were some data that showed that perhaps there was some inhibition of the extrinsic pathway. So you have increased tissue factor pathway inhibitor, which caused a hypercoagulable state that stopped the bleeding. So should we be measuring DOAC levels before we use Andexanet?
Easy question. No, I'm kidding. Thank you for the comment. Really important comment. In the ANNEXA-4 trial, about a quarter of people were found to have levels of factor Xa inhibitor that were less than 75 nanograms per mil. That was the cutoff. Less than 75 nanograms per mil. That was the cutoff that was used for entry into the efficacy population in order to evaluate efficacy, because you want to evaluate efficacy in people who have high enough levels to warrant reversal. It is a big clinical challenge. And many people, so there is a need for a point-of-care assay, a good point-of-care assay that tells us whether or not someone has clinically significant levels or not. I think part of the secondary challenge of that is not that they're not just that those aren't available with rapid turnaround time and that are reliable and accurate, but also that we don't really know what that threshold should be. And, we have some thresholds have been proposed by, experts at the ISTH of, 30 or 50 nanograms per mil, but we don't really know. So important, I think, for future research to understand exactly what levels we should be targeting and working towards point-of-care assays. My understanding is that there are lots of them in development, so hopefully we'll see something like that on the horizon. And I'm sure there are a lot of presentations here about that. At our site, I think for intracranial bleed, if somebody has a parenchymal intracerebral hemorrhage, I would not wait for the results of a test in order to treat. You're just going to treat. They took their dose 6, 8, 10 hours ago. They have a big bleed in their brain, and time is brain. Like that, we know that hematoma expansion predicts outcomes. And so I didn't show these data, but one of these sub-analyses that has been presented from ANNEXA-I is that people who had hematoma expansion had far worse outcomes including functional impairments, severe functional impairments and death, compared to those who didn't have hematoma expansion. So you actually, that is important. Other types of bleeds, maybe you have some time. But I think we're advocating now for people using a clinical assessment to determine whether or not someone has levels or not. But it's a good point. And then I think, again, with that, get people back on their anticoagulants when it's safe to do that, or prophylactic dose of something, or intermittent pneumatic compression devices, right?